Well, thank you very much. This is a very nice session, beautiful images. I like the presentation. Maybe I disagree a little bit. For instance, I see more than 4 causes of respiratory failure. For instance, fifth one is diaphragm dysfunction. So I'm going to tell you about that. I also disagree on the fact that it's difficult. I think you mentioned that. Well, I'll try to show you. So one of my greatest pleasure in my professional life is to work with clever, young, dynamic people who collect the data and which I can present in my slides. So this is why I put their names, because this is really the science of Dimitri Matamis, Emmanuel Vivier, Franco Sferrazza-Papa, Martin Dress, and Johan Golliger. So the diaphragm is a very special muscle, very interesting, and central to ventilation, right? Without diaphragm, you're in big trouble. It's a muscle which is it's quite unique. It's different from the other limb muscles. It's also different from the heart, although it has some resemblance with the heart. And it has a complex shape. I think probably the most useful way to look at the diaphragm, how it works, it's like a piston. It's like a piston going up and down, so going down to create negative pressure in the chest and to fill the chest. So the contraction can be made, by instance, by the pillars of the diaphragm. And what you see that the zone of position of the diaphragm is progressively reduced when the diaphragm is contracting and shortening. So let me try first to convince you that having more assessment of the diaphragm is something probably important and which has been underestimated until now. The best technique for the gold standard technique for assessing diaphragmatic force is to stimulate the phrenic nerves and measure the contraction of the diaphragm. So one way to do it is to use magnetic stimulation, stimulating the phrenic nerve in the neck and measuring the pressure generated by the diaphragm. For instance, in an intubated patient, just the tracheal pressure is a good signal. It reflects the change in esophageal pressure during an occlusion. So you occlude the airway, you stimulate the phrenic nerve, and you have, let's look at the second slide here. You have an abrupt decrease in the tracheal pressure, so twitch pressure, which normally is about like 30 centimeters of water. And the weak patients, the patient with a weak diaphragm, will have twitch pressure, well, below 11 or 10 centimeters of water. So this is the, let's say, gold standard technique to assess diaphragm weakness. This is explained in this recent review, which is just published a few days ago in Intensive Care Medicine for those interested. This is, of course, a complex technique, and we are not going to use that in the ICU, but it was useful to, for instance, bring very important information. This is the study comparing the clinical assessment of limb muscle weakness, the MRC score, and this twitch pressure that I just showed you. And this was a series of 76 patients at the time of weaning from mechanical ventilation. And the first question is, at the time of weaning, how many patients have limb muscle weakness? How many patients have diaphragm weakness? So the limb muscle weakness would be below the MRC score. The diaphragm weakness would be below this 11 centimeters of water threshold. And the first result is that 63% have diaphragm weakness. 63%, that's enormous. And that's much more frequent than limb muscle weakness. So the two are not related. It's probably, there may be some overlap, but it's not the polyneuropathy we see in the ICU. And why is it important? Well, it's important because it has an enormous influence on the weaning outcome. This is, for instance, the percentage of patients who have diaphragm weakness or dysfunction, when they have simple weaning, when they have difficult weaning or prolonged weaning. Well, almost 100% of the patients with prolonged or difficult weaning have diaphragm weakness. This is incredibly important. With simple weaning, you have patients with diaphragm weakness. So weakness does not mean that patients are unable to breathe, and there will be patients able to be extubated. But if they have diaphragm weakness plus some infection, plus some fluid overload, plus anything else, they will have very difficult time to cope with these two problems. So clearly, it's very relevant for clinical practice and outcome. And assessing the diaphragm thickness and function, in fact, is not so complicated. I can tell you it's not so complicated. We are now training our respiratory therapists in the ICU to do that by themselves. So I don't think it's a very complex technique. You need some training. You need to take the ultrasound machine from Laurent Papazian or for the previous speaker, but you just need to change the probe. Because the diaphragm is so close to the skin that you need a high-frequency probe, like 13 megahertz, which is not the usual probe. And then you can quite well visualize the diaphragm. I will show you some precise data. Between the pleural layer and the peritoneal layer, it's easier to see on the right side because of the lever. And you can see the motion of the diaphragm and the contraction of the diaphragm. In fact, there have been two techniques. I'm just showing a number of review articles which have described that, so you can really find a good literature on that. The first technique which was used was just looking at the motion of the diaphragm and what is the diaphragmatic tidal excursion, or what is the maximal excursion when you do a sniff test. Sniff test is, did you hear that? Okay, very intuitive. So it's a way to contract your diaphragm, or to do a deep breath. And the excursion, we have some normal values. This was a nice study by Boussuge in a large number of cohort patients. You see the normal values. So in the ICU, the big limitation is, of course, if you look at the diaphragmatic excursion during ventilation, you don't know how much is due to the ventilator, how much is due to the diaphragm activity. So it may be useful. Some people have said it predicts weaning failure, but this may be not the best technique. By putting the probe differently, you can really assess the diaphragm thickness, and again, you need a special probe. You can see here some normal data saying it's about 2 millimeters. The precision is about 10%. And in addition, what's really interesting is that you see the diaphragm contracting. At every breath, when the diaphragm contracts, it thickens. That's what a muscle is supposed to do, right? To thicken and to shorten. So this is an example from Martin. I think Ty was a healthy volunteer doing a big effort, so we can see very well. So you see during quiet breathing, you measure an expiration, and you can calculate the thickening fraction, which is like 30% usually. And you see during a bigger effort, so you see a big contraction, and this was a very, very strong effort. So with this technique, you can see the morphology, you can calculate the thickness, and you can see how much the diaphragm is thickening. What does it mean? Well, it's probably a little bit complex, but for instance, this is a study we did with Emmanuel Vivier, measuring the PTPDI, so complex measurement with two balloons in the esophagus and the stomach during spontaneous breathing. It was patients just extubated and receiving non-invasive ventilation, and with 3 levels of pressure support. And you see, as expected, that the the work of the diaphragm is going down. Well, this is exactly what we see with the thickening fraction. You see a very nice correlation between the change in thickening fraction without pressure support and with increasing level of pressure support. So you have the information of how much the diaphragm is working, and we know a little bit now about the normal value and the value show below the normal threshold. This is a study including something like 100 patients in the ICU and showing what you can measure if you give neuromuscular blockade, and as expected you measure something close to 0, of course. So it's not exactly 0, maybe some patient had partial blockade. And you can compare to LC subject at rest. You see it's around 30-35% on average. You see what is measured during controlled ventilation. So patients are supposed to do very little, and they do very little. It's probably 10% of thickening fraction. Interestingly, in this series, when you look at patients under partial assisted ventilation like pressure support, well, you suppose they are close to the normal LC subject. In fact, no, most of them are doing also very little. And this is one of the reasons why we may have so many patients developing diaphragm atrophy. You may not see very well, but if you are interested in the details of how reproducible it is, what technique should be used, this is very well described in this paper. The reproducibility for the thickness is very good. The most difficult part is the thickening fraction, because you have to be sure you don't move, you are at the right place. And the two tips to do that is to use the right side, which, as I said, is much easier. And also, so if, of course, the right side is completely different from the left side, this is a limitation. And also to put a mark on the skin if you do several measurements. And we found, for instance, that the reproducibility was much better when there was a mark on the skin, so you can reproduce from a different observer. Another question which was addressed here is when you change lung volume, does it change the thickness? And to make a long story short, it was shown that when the change in lung volume are not huge, it doesn't change really the thickness. So the increase in thickness you see during contraction are not explained by change in lung volume, but are really explained by diaphragmatic contraction. If you go to very high lung volume, then you may have an effect of the lung volume by itself. So I think we know quite well how it works and how it could be used clinically. Let me now show you some results to see that it does mean something, which suggests that this tool may be used clinically more often. So this is a study really run by Ewan Golliger, which really show impressive data, because this is the everyday life. This is 110 patients consecutively enrolled in 3 ICUs in Toronto, and in whom we measured the diaphragm thickness day after day. So it's not a selected population, except patients who were supposed to stay at least 24 hours on the ventilator. So no clinical protocol, just measuring the thickness day after day. And we found 3 behaviors. One is the red curve, and represent 40% of the patients. And these are patients in whom the diaphragm thickness decreased by more than 10%. 10% was our limit because it's a limit of reproducibility. So 40% in the ICU develop diaphragm atrophy. Then we had another 40%, this is the green curve, with really no change in diaphragm thickness. So patients who have no, let's say, injury due to ventilation. And then there was another group of 15-20% of patients who increased their thickness, which was surprising. So we say maybe these patients are developing new muscles. But we don't think it's new muscles. We think it's probably injury and edema in the muscle. Because when we tested the diaphragm function in the 3 groups, we found a normal function in this group, but we found a dysfunction, a weakness, both in the group with decrease in diaphragm thickness and the group with increase in diaphragm thickness. So by working too little, this group, or too hard, this group, you develop diaphragm dysfunction. How can I say that? Well, there was this interesting, complex but very interesting analysis about the factors explaining the change in diaphragm thickness. So this is a 3-dimensional graph, right? So please take a few seconds to think about it. What you see is that the change in diaphragm thickness are first explained by the duration of ventilation. Okay, the longer the duration of ventilation, the larger is the decrease in thickness and atrophy. But then another important factor was the diaphragm contractile activity. And remember, we can assess this contractile activity by looking at the thickening fraction. And when the thickening fraction was very low, let's say below 20%, this increased the occurrence of atrophy. When the diaphragmatic contractile activity was in a normal range, 30–40%, well, there is no change. But in those in whom the diaphragm contractile activity was high, so probably they were under-assisted, there was this increase in thickness, which probably indicate diaphragm injury. Very, very interesting data. The interpretation is probably a little bit more complicated. This is a beautiful graph done by Emmanuel Vivier, looking at a series of patients with diaphragm thickening fraction. And what are the clinical determinants of this thickening fraction? First, on the right side, this is just the same correlation than I showed with the data from Martin with the phrenic nerve simulation. This is the MRC score versus diaphragm thickening fraction. There is absolutely no correlation. So a confirmation that diaphragm weakness is not limb muscle weakness. And to look at the different factors which were explaining, so the closer you are from the center, the stronger is the correlation with the dependent variable, which is the thickening fraction. And you see that a significant correlation, a negative correlation, was sedation. Of course, the more sedation you give, the less thickening fraction you will have. So it's obvious intuitively, but the more we give sedation to our patient, the less they will work. And a positive correlation was the underlying presence of COPD or cardiac dysfunction or cor pulmonale. So cardiac or respiratory problem will make the patient working more and maybe sometimes excessively. So I think it's an interesting observation to try to interpret the thickening fraction at the bedside. So after the first study, Yuan decided that we needed to know whether this diaphragmatic atrophy or this increase in thickness was associated with outcome.
Laurent, could you conclude, please?
Okay. I showed you some previous data showing it's associated with winning. This new study, just online in the Blue Journal, show that it's very, very strongly associated with a decreased likelihood of liberation from the ventilator, whether it's a decrease in sickness or an increase in sickness. And it's also associated with more complication, including death in the hospital, reintubation or tracheostomy. So very strong association with outcome. So I think in conclusion that diaphragm weakness and dysfunction is a major contributor to prolongation of mechanical ventilation. The delivery of assisted ventilation has a strong influence, and monitoring respiratory muscle activity and personalizing ventilation based on this assessment may be necessary using diaphragm ultrasound or other techniques. Thank you.